Thank you. Malcolm Moore from Public Health Wales. Peter, thank you very much for a really captivating first presentation there, looking a lot at the evidence. And there's obviously an emerging and burgeoning evidence base around risk reduction regarding dementia. But I'm guessing, you already suggested that, for example, blood flow is an area that needs further research. Are there other areas you think that we need to start thinking about in bolstering that evidence base around dementia prevention or dementia risk reduction?
Is that an impossible question? We don't know what we don't know. There's so many areas. I put up about 12 factors which would be worth looking at. But they raise all kinds of difficulties, reverse causation, residual confounding, and so on. And ideally, there should be randomized controlled trials done to see, are these independent factors predictive of dementia? I've indicated diabetes as something I think we could be well occupied for the next 10 years, doing something really effective on body weight, reducing diabetes, a mass of complications and costs from that, and at the same time reducing the extra 50% of diabetes of dementia that diabetic patients experience. Other than that, sticky blood is just, with my background in ischemic heart disease, that's particularly interesting, and I gave that a lot. But that's back to pills, and I think the impact is likely to be small. I'm fumbling, and I think I've probably said enough, but thanks for your stimulating impossible question.
Anyone else?
So, Mark Griffiths from Public Health Wales, R&D. Both Phil and Peter, you talked about the difference in health outcomes between manual versus non-manual workers, and also the contribution that auditory hearing loss will make to dementia. And I think, Phil, you touched upon quite a lot about social connectedness. So do you think an additional lifestyle factor, you talked maybe, Peter, about optimism and psychological factors, but this could be to do with social connectedness that could help prevent the onset?
What's the question?
The question was about social connectedness. Is that a further healthy behaviour that could lead to the prevention, reduction of dementia?
Yes, I think Sue and Nigel have illustrated that there's a great tendency to withdraw, and loss of hearing leads to people withdrawing, and I won't go to the club anymore because I will be exposed, I'll be isolated. Involvement is very important, but you say something about that, something more.
I would absolutely say that social connectedness, inclusion, and living your life and being stimulated, doing what you want to do with others is absolutely a lifestyle improver. And I can use my mother-in-law as an example. Mum-in-law has dementia. She has done exactly that. She has withdrawn, despite all efforts. She finds it difficult to come to terms with her dementia and doesn't want to be in the company of others. She feels embarrassed by it. And she spends hours and hours on her own with no conversation and no stimulation. And I think that has exacerbated her symptoms. So I would definitely say where you can is to continue to be active and involved. I'm sure Nigel would say, well, Nigel is a living, breathing example of this, but yeah.
A factor I didn't mention very much because I don't think it's as important in the UK and in modern industrial societies in terms of one of the things the evidence base demonstrates is about education and the duration of people being in education, and that as a protective factor. And we have seen internationally that for women in particular, the impact of not staying in education for a prolonged period can impact on that. And I guess, I don't know, I'm not a scientist, but I guess that's about how we put our memory down and how we use our brain and how being cognitively active is protective. And obviously, if you have a job which requires you to use your brain and routinely, then that will have an effect. And of course then the issue in terms of being socially connected is also as stimulating. So the less stimulated you are, the greater the potential is that the benefits of being stimulated cognitively as a protective factor will be greater. So I guess there's a lot in the impact of being isolated. And we know, I mean, if you look at the other health benefits of isolation, we know that we're beginning to see, you know, the impact on premature mortality of being isolated and lonely, and that can have I'm told it's a significant effect to smoking 15 cigarettes a day. So it's something. It's another public health challenge we should be confronting, and it is an area, I think, in terms of social connectedness, that is a protective factor. But again, it's one of the things that I'm a bit concerned about in terms of the impact on austerity, because those kind of societal and investments at a community level that enable people to be connected are diminishing and are impacted upon some of those things. So that's a further concern, really. Do you want to add anything to that, Tony, in terms of the science about...
Yeah, I guess that there's a concept of cognitive reserve, so how much we've sort of got in store to use if necessary to bring out. And so the theory is the more education we have in childhood and young adulthood, we build up more cognitive reserve. So therefore it is relatively protective when we start smoking, get overweight, all the rest of it. It doesn't prevent us, but it delays us. So in a way, it's a good thing to build up the cognitive reserve in while the brain is maturing. But then presumably we need to actually do something through adult life to maintain the cognitive reserve and not chip away at it. And so lifelong learning, social networks, really throughout adult lifehood. And it's always dangerous to use sort of animal models, mouse models. But if you go and get a mouse that has a genetic makeup that it's going to develop Alzheimer's type changes in the brain, if that mouse goes and actually lives in a rather boring laboratory cage, you know, it's well fed but not much stimulation, and you compare it with the mouse that actually goes and lives in a larger cage and has your wheels to go round and has other mice over for sleepovers and, you know, much more sort of varied life in the first 2 or 3 months of that mouse's life. If you then measure the changes in the brain later, the stimulated mouse in childhood has much less amyloid, much less of the pathological changes in the brain than the bored mouse. So you can't do, you know, as Peter said, randomised controlled trials is really what we need, but that's very, very different. Impossible to do at a population level, and so you can do it in a laboratory setting with animals, and okay, a mouse is not the same as a human, but you can extrapolate from one to the other.
I know certainly when the Health and Social Care Committee did their recent inquiry into loneliness and isolation, they called it a public health epidemic. And I think it is a whole life course. So you can have that cognitive reserve, but then it's what happens throughout your life trajectory. You need that support network of other people around you throughout life's events. And what they found, even towards the end stages of dementia in care homes, is that those care homes where people are left in a circle, bored, nothing to do, isolated, even though there are people around them, those care homes very often have people on a quicker decline and end-of-life pathway than those care homes where people have meaningful purpose. So I think across the whole life course, there is a huge risk of not supporting people to engage with them positively And that's where the whole well-being agenda comes, because if we don't do that, we are literally killing people from boredom. Nigel.
Okay. There's a lot of conversation about engaging with people living with dementia or people affected with dementia, but the issue is bigger than that. My best form of support is peer support. They act as a cognitive bridge. I'm sure somebody's told me that. I'm not sure I haven't made that up, but they act as a cognitive bridge. And the more active you stay, the more places there are for you to go, more things there are for you to do. It's proven that you can stave off the worst effects in some cases of dementia. But Daisy's quite right. The challenge is huge, because while we're pushing on ahead for maybe the people who are more able than others, we must make sure we don't leave behind anybody. Nobody gets left behind. No mother, no father, no lover, no brother, no sister, no aunt, uncle, grandfather. Nobody gets left behind. We take everybody on the journey. We take the conversation into nursing homes. We take the conversation into people's homes, and we take the conversation to the wider general public, because we can't overestimate the impact of dementia on a family. You can't just lie about it. It's huge. And it's something which cannot be dealt by just one organisation. Engagement works. A good lifestyle works. So they're looking at me, I bet you're thinking, what sort of lifestyle does he live? Well, yes, I like a drink, and I like going out and eating. Yes, of course I do. But I mean, you have to take account of the dementia. You have to work with it, not against it. And when people start working with it and not against it, and ignoring the cognitive effects, but looking at the physical effects and helping people overcome that. Give you an example. The thing about going out and talking to people, you find the most wonderful unintended consequences. I went along to dementia-friendly Swansea YMCA. Hands up, those who know Swansea YMCA. No? Okay. Oh, you do you? Okay. All right, you do. Okay. It's like the TARDIS. You go in through that door, and it's huge space. And the guy there has a wonderful backstory, and he did a much better job of this than I did. But we looked at it and we thought, oh yeah. They've got a fully functioning gym. Well, get this, a guy who runs the gym used to be in stroke recovery. There you go. It's quids in. It's going to be I think it's going to be I'm very excited about it, because they've got a fully functioning theatre upstairs. So all of these facilities are out there. And all of these, nobody will ever say, right, well, I don't want to do anything about dementia, because they won't do. They're like monsters, especially if you're talking to somebody living with dementia. And if you engage us, and if you take us with you along that journey, then you're going to get better results. So one thing I would say about research is that sometimes it's done in isolation away from the people who are living with it. I know that's slowly and surely changing, and I know that people with dementia play a major part of research now. And I can only say that the more that's encouraged, the better it is for the end results.
Thank you. Any further questions?
Can I raise the issue of blame?
Yeah.
Smoking is now socially unacceptable. Why are we told that we mustn't blame people for being overweight? Is that reasonable?
What do you think?
I made it quite clear in my
Yeah.
talk.
Yeah, I'm just putting that across to the panel members.
But what purpose is it to blame people?
Body weight is under our own control. And if we're overweight, we have a high demands on health service.
But do you not accept there are structural inequalities that do make it more difficult for...
We can use that excuse for almost any condition.
Yeah.
Yes.
I think there are structural inequalities. It doesn't make an excuse for it.
Somebody with an addiction to cocaine will say exactly the same. You've got to understanding.
Yeah, I think that might show
It was your slide.
Yeah, it was my slide, and I'll own it. I much prefer the language of looking at a co-produced health and social care system. because I think that there are a number of factors here, and I think that one of the things that I'm not sure is working at the moment is the nature of our relation as consumers, and I include myself as a consumer of healthcare on occasions, and that healthcare system. We have a responsibility for our own health, and we should have a relationship with health that gives us the information that we need and supports us to live a healthy lifestyle. I think though that relationship is key. I think sometimes that relationship in terms of co-producing our own health, which is I have to take responsibility for myself. I have to have, firstly, the information that I need to be able to make choices. I think you're right, there are structural issues in terms of poverty, material poverty, that can impact on lifestyle choices and on education and understanding about issues of lifestyle. But I think having a co-produced health system where we're beginning to increasingly reduce the patriarchal or matriarchal relationship between the healthcare system and the person that engages with it is important. And I think the discussions we've had around co-production, around the necessity for people to understand their own responsibility and the fact that they can then rely on healthcare systems to support them when they become unwell. But it doesn't all start at the hospital door. It starts much earlier in terms of how families behave, about how we're educated, about our understanding of our own health, and the choices that we take. And I think seeing it as co-production rather than blame is probably more helpful.
Do you want to come back on that?
No, well, one of the things I was going to say, that in the, I think it is the campaign about the getting the 6 messages across, and it is insert before what was known in the community before and what was known in the community following the campaign, and basically there was increased awareness and things like that. I think people tend to know a lot of the facts. I think there's increasing evidence, of course, about the potential to reduce your risk, etc. But it's still not, and I've done some research on this as well, it's still not getting out there to a lot of people. There's still the fear, there's still denial, there's still the, what's the point in doing anything, you're buggered if you're, there is still these attitudes. So, and I think this, as you've termed it yourself, this paternalistic attitude of blaming is actually putting people off some of the public health messages. I think co-production and understanding where people are at is a much better way of actually making sure that we are getting the messages across in the right way, that people are likely to uptake the messages, which I think are all absolutely key. We have to do it, but there's the way of presenting things and likelihood of increase and uptake in the way that we do it.
I think helping people to translate those messages into real life issues. So the 5 words to well-being, we talk about that, but what does that mean to the average person in the street, as an example? The analogy I always take is if you look out that window, you'll see an allotment. And I always feel an allotment, and the allotment, I don't have an allotment myself, but I quite like one. But I think that's a really good example of how the 5 ways to well-being can translate into something which is meaningful and understanding and realistic and tangible to somebody. So it gets you out in the open, it gets you to mix with other people, it allows you to grow fresh fruit and vegetables, it gets you to share, because you can never eat as much as people grow, in my experience of people run over the allotments. And I think that's a really nice way of translating some of the messaging into something that people could do, which would be a lifestyle change that would bear fruit in a whole load of those areas. And I think it is about what do some of these messages mean in terms of how you move from where you are to where you want to be, and enabling people to make some of those changes in their lives, because they can be challenging for people whose experience is very limited in terms of, and I don't want to sound patronising, but I think sometimes for people who are on very low incomes who've not perhaps had exposure to healthy eating, how you move from one diet to a diet which is more healthy. There's no end of TV programs about it at the moment, which I think is a positive thing. but it's actually about how you translate that and enable people to make realistic lifestyle choices, like you said, parking your car and walking a mile, committing to walking for 20 minutes a day, things that are within people's grasp, they can understand and are enabled to make that change. I think that's a really important part of following up public health messaging, is actually translating.
If you do make these changes, even in the presence of dementia, it has a positive effect.
Yeah.
Because when I was first diagnosed, I became very, very isolated, and I lived alone, and my stepbrother was in America. He used to order my food for me. I used to get 3 deliveries of food a week, and it was all fillet steak, stuff I could eat easily, because money wasn't a problem, and Jack Daniels and red wine, and no fruit, no veg, and I thought the only reason you had lettuce is if you had a rabbit. And I went up to 29 stone, and I think I may have consciously decided that I was going to eat and drink myself to death, and I was well on my way. And then something happened. 3 very annoying women from the early onset, the dementia team knocked on my door, and they colluded with my neighbours. They went through my fridge and threw things out. And they colluded with my neighbours, they colluded with my stepbrother, they colluded with everybody. And I still need to go on a diet again with the roly-polies, but I'm a lot better than where I was. My blood sugars were 20 odd, and my BP was 210 over 130. I was a stroke waiting to happen. But I couldn't do it alone. Like, lots of people out there haven't got the access to that help. And it's all very well, you can have as many campaigns as you want, but the reality is I live in the Free Republic of Town Hill, where a lot of people would be below the poverty line. And if you were struggling on a daily basis to put food on the table, you're going to go for the cheapest option. And it might not be the healthiest option, but it's going to be the cheapest option, which is kind of different to me, who had lots of money, and I was always going for the stuff that I wanted to eat. But living well with dementia and healthy lifestyle go hand in hand. You can't do one without the other. And we preach all about, going out there and doing things and engagement. But if you can't walk, 200 yards like I couldn't without your back killing you, then you're not going to go anywhere, and you're going to be happy sitting at home and put your head in the fridge every 5 minutes just to bang it off. I think there's been a criminal negligence by Welsh government, by UK government on the health issues and the diet issues, and I concur with everything that you say here, that it is people's faults. But I think what we need to do is understand, where you've got kids going to school, where teachers are having to buy food because the kids are hungry, where teachers are having to, wash kids' clothes, where mums are passing out outside because they haven't eaten for 2 or 3 days. These are issues that need to be addressed before we start talking about the health benefits of lettuce. These are things that need to be addressed. These are things that need to be talked about. And they're not being talked about. They've been swept under the table. I was lucky enough to be part of a group that gave evidence to the UN Committee on Disabilities in Geneva. And the end result was, and it's not hit the headlines, it should do. I mean, if it was about Rohingya or something like that, it would do. Catherine Gemia, who's the head, is the chief, who's the senior rapporteur for people who live with disabilities, says that the situation for disabled people in the UK is catastrophic. She said it from the evidence that she heard. There are 129 signatories to the United Nations Convention on the Rights of Disabled People, and amongst them are such wonderful paragons of human rights like Pakistan, Saudi Arabia, Iran. We are the only country that's on a watch list. We're on a watch list. The UN are looking at us because the way this government treats disabled people. That's where the fault lies. It's easy to blame the people down below, but that's where the fault lies. If you suddenly are put on universal credit and you have to feed a family of 4 on £27 a week, you're going to struggle. You're going to struggle. I work at a food bank at weekends through my church, and the most popular food is stuff they don't have to heat up. It's pot noodles, it's a cup of soups, it's bread. So I take aboard everything that you say, but the social reality in this country is that people can't afford to be healthy.
Okay, so yeah, I think there is still work to be done around also how we actually incentivise people to think there is more than life than sitting on the sofa, and there is work, as we were talking about earlier today, Tony, about making the messages positive messages so that it still won't reach out to everybody, but at least those people who we can possibly reach out to will start to get something that's more appealing. Because from an early age, I remember with my niece, it's don't tell me what to do. And I think that is something that sits at the back of our consciousness with any public health message. And actually, I think with the 5 ways to well-being, connect, be healthy, there is a way of making those friendly, of relaunching them so that they're actually something that is much more appealing and connecting to people with a wider public health programme. So, any further questions?